we've got, we were privileged
Recording in progress.
Of a patient with urinary incontinence. Dr. Nwalo is going to be the presenter. He's put in a lot of effort and into this talk. It's quite a broad topic, so we tried as best as possible to sort of streamline as much information in the within the hour and hopefully have a few minutes for some comments or questions at the end. Urinary incontinence in women is quite an underrated topic and often overlooked, and even as gynecologists, we tend to, not really have a good understanding of how to approach these patients. So we're hoping today we can improve everyone's approach to urinary incontinence. Yeah, so I'll leave it to Dr. Nwalo.
Thank you. Morning, everyone. I'm Dr. Nwalo. I'll be presenting on the evaluation of a patient with urinary incontinence. The talk was supervised by Dr. Naika. For the purposes of this talk, we, as opposed to an outline, we opted for to have only 3 objectives that we're hoping at the end of the talk that the audience will be able to learn how to assess the patient with symptoms of urinary incontinence. They must be able to appreciate how to use the investigations appropriately. They must be able to understand how to choose appropriate treatment. I will start off by saying, by this quote, that urinary incontinence is known as the social cancer that adversely affects a woman's quality of life. And that's where really the crux of the matter is, that it negatively affects a woman's quality of life. It is defined as a symptomatic complaint of involuntary loss of urine. It is a clinical condition and it's not a disease itself, but it has a profound influence on a woman's well-being and quality of life. It's a global medical problem that is observed in all groups in different countries, cultures, and ethnicities. And it has a huge economic burden on healthcare services. It's often underestimated and underdiagnosed in both developing as well as the developed world. Its prevalence varies in different countries. This is because different countries use various definitions of urinary incontinence. They use different assessment tools. However, we do know that it is more common in women than men, and the reported prevalence of urinary incontinence among women varies widely. Most studies, they say it range between 25 and 45%, and we know that the prevalence increases with age. It can affect up to 58 to 84% of the elderly population. However, 1 in 4 non-elderly women are still affected by urinary incontinence. In South Africa, based on community-based studies, they've reported the prevalence to range between 14% and 67%. This was just taken from a systematic review and a meta-analysis that came out in August this year. It was a collaborative effort by the International Continence Society as well as the Iranian Research Center for Evidence-Based medicine. If you can see on this map, we are sitting at around 24.7% in the sub-Saharan Africa, with the Middle East and North Africa at around 38.2% being the highest. Of course, with variations in the prevalence in different parts of the world, there must be barriers that are associated with this patient, or that are preventing these patients from preventing or seeking medical care. So this was one study again that came out last month in Saudi Arabia, where they looked at 505 eligible participants. They noted that the most significant barriers were embarrassment, logistic inconvenience, whereby either the patients, they got a data that was either too far or they're staying too far from the hospital, or provider-related issues where in certain areas of the world there's a lack of available providers to actually assist. Of course, obesity as well as type of urinary incontinence also contributed, particularly obesity, where those ones tend to present much more later in fear of being discriminated and so forth. So this was the 2016, the International Urogynecological Association, as well as the International Continence Society. They came up with this joint report. It was a terminology paper for female pelvic flow dysfunction. And basically, the list is much more longer than what we presented here. However, we focused on the three main clinically important types of urinary incontinence, as well as the new types of incontinence that were in that paper. So the ones that are of clinical really importance is the ones that we highlighted. So where they said stress urinary incontinence is a complaint of involuntary loss of urine on effort or physical exertion, whereas urgency urinary incontinence is a complaint of involuntary loss of urine associated with agency. Mixed urinary incontinence is a complaint of involuntary loss of urine associated with agency and also with effort or physical exertion and or sneezing or coughing. Whereas postural urinary incontinence was a complaint of involuntary loss of urine associated with change of body position, such as rising from a seated or a lying position. Nocturnal enuresis is a complaint of involuntary urinary loss of urine which occurs during sleep, whereas continuous urinary incontinence is a complaint of continuous involuntary loss of urine. Insensible urinary incontinence is a complaint of urinary incontinence where the woman has been unaware of how it occurs, whereas coital incontinence is a complaint of involuntary loss of urine with coitus. It may further be divided into that occurring with penetration or intermission and that occurring at orgasm. There is also incontinence associated with chronic retention of urine, functional incontinence, and multifactorial incontinence that are there in that paper. When we look at the physiology of micturition, it is defined as the coordinated process of urine storage and voiding. It is controlled by neural reflexes and involuntary pathways. It consists of a storage phase and the voiding phase. In the storage phase, the bladder accommodates increasing volumes at low intravesical pressure, and the detrusor muscle is relaxed and the urethral sphincters are contracted. In the voiding phase, it is initiated when the bladder stretch receptors signal fullness to the pontine micturition center, and the detrusor muscle contracts while the urethral sphincter relaxes. The rise in the intravesical pressure causes the outflow resistance to fail, leading to the expulsion of urine. So basically, we're saying normal voiding ends with complete bladder emptying and the resumption of storage phase. And when there is a disruption of any neural or muscular component, this will result in urinary incontinence. There is a role also played by the neurophysiology. We're saying regulation of maturation involves cortical, subcortical, brainstem, and spinal cord. There's a role played by sympathetic nervous system between T10 and L2, which maintains the bladder neck closure via the alpha-adrenergic receptors. Also, the parasympathetic nervous system between S2 and S4, this one mediates the detrusor contraction during voiding. There's also a role played by the somatic nerve, particularly the pudendal nerve, which controls external urethral sphincter and pelvic floor contraction. So there must be voluntary and reflex control, which ensures coordinated relaxation and contraction during storage as well as the voiding phase. Just for reiteration, basically, we're saying that the lower urinary tract function, it consists of two phases. It's the storage phase as well as the voiding phase. It consists of two structures, the bladder and the urethra. And in a normal case, in the storage phase, you'll have detrusor relaxation, and while you're having a urethral sphincter contraction in terms of urethra. In the voiding phase, you'll have detrusor contraction while you're having a urethral sphincter relaxation. Of course, then there will abnormal states where you can find that within in the storage phase, you'll have detrusor overactivity or you'll have sphincter incompetence. While in the voiding phase, you may have detrusor underactivity or acontractility, as well as urethral obstruction, dysfunctional voiding, and so forth. When it comes to the risk factors, again, even the risk factors we look at according to the subtypes of urinary incontinence. So we say basically if you are younger than 50 years of age, you're more likely to end up with stress urinary incontinence, whereas if you have obesity, diabetes, COPD, all that seems to cut right across the three different subtypes. Of course, with increased parity, particularly if it's vaginal deliveries, you're at risk of ending up with urinary incontinence. Operative vaginal birth, you're at an increased risk of stress urinary incontinence, with increasing age and menopause, previous hysterectomy, as well as high BMI, which is a well-established risk factor. With high BMI, there's many studies who have showed that obesity as a risk factor for urinary incontinence. Also, systematic hormone replacement. There is a Cochrane review that was done in 2012 that showed that systemic hormone replacement therapy may worsen urinary incontinence. When it comes to the reversible causes of urinary incontinence, there is an acronym that we can use, which is called DIPAS, where D basically is for delirium. Here we are saying that in an acute confusion, that can reduce awareness of bladder filling, and then with infection, UTIs can increase urgency and frequency, and with atrophic urethritis and vaginitis, and postmenopausal, with postmenopausal estrogen deficiency, the thinning of the urethral or vaginal tissue causes irritation as well as incontinence. And then with pharmaceuticals, drugs like diuretics, sedatives, anticholinergics, opioids can affect the bladder control. With psychological factors, depression, dementia, it can reduce the motivation, the motivation or ability to maintain continence. Whereas with excess urine output, conditions like uncontrolled diabetes, heart failure, or diuretics leads to polyuria. And with restricted mobility, that's where you get functional incontinence when a patient can't reach the toilet in time due to mobility issues. Here, it's not really the issue of the lower urinary tract system that is a problem. It's just because the patient is impaired and they can't really get to the toilet in time and they become incontinent. With stool infection, fecal infection, it can compress the bladder or the urethra, thus worsening the incontinence. So when we're evaluating these patients, we've got to look at them again according to these three urinary subtypes, the stress urinary incontinence, edge urinary incontinence, as well as mixed urinary incontinence. This is just for clinical purposes as suggested by the International Urogynecological Association as well as International Continence Society. So we always start with history, of course. It requires the caregiver to assess the patient in a holistic manner. It includes elucidating the type and the nature of incontinence, the frequency and the severity of the disease. It also requires the healthcare worker to review other systems as well that may be involved, where you look at for the presence, the duration of any urinary, bowel, or prolapse symptoms. You have to be able to identify symptoms in the related organ system, as that is critical to effective treatment planning. You have to make use of validated questionnaires to assess the symptoms, and you must be able to determine the impact that the leakage has on the patient's daily life. And also, if the incontinence limits the individual's activity, and if the patient has made lifestyle changes because of the risk of leakage. These were just the questions that were taken from Novas just to assist us in terms of how to phrase our question as to whether to be able to actually ascertain as to whether which type of incontinence that we are dealing with here. So like for instance, I won't go through all of them, but let's say like with question number one, we'll ask the patient, do you leak urine when you cough, squeeze, or laugh? Of course, that will be stress urinary incontinence. Do you ever have such uncomfortable, strong need to urinate that if you don't reach the toilet, you will leak, which will be urgency? And if yes, to question two, do you ever leak before you reach the toilet, which will be urge incontinence? And then how many times during the day do you urinate, will be frequency, and so forth. All the way, do you ever leak during or after sexual intercourse, will be coital incontinence. There are validated questionnaires which assist us to evaluate the impact of urinary incontinence. One that is recommended really is all of them are recommended, but the one that in the International Continence Society guidelines of 2024 that they speak about as being a grade of recommendation, a questionnaire is the International Consultation in Incontinence questionnaires. Of course, others as well can be used. We then want to go on to find out about the impact of urinary incontinence that it has on the patient's sexual function. There are also validated questionnaires for that, which including impact on the quality of life, which are useful part as a part of a full assessment. You also want to find out about the presence and severity of symptoms suggesting neurological disease. And yeah, really, I was just trying to show you the available sexual function questionnaires that you can use. Well, then we'll go on to your medical history. Previous conservative medical and surgical treatment, you want to find out about that, as these will affect the genitourinary tract and lower bowel. You want to find out about the effectiveness and side effects of the treatment, that the patient has been on, and you want to find out about the coexisting diseases that may have a profound impact on the patient with incontinence and prolapse. One example being asthma, which these patients will suffer really greatly during the attacks. You want to find out about the diseases that may also precipitate incontinence or make it more likely than not, particularly in frail older adults, and you will then review the patient's medication. It is always important to review every patient's list of medication and to make an assessment as whether the current treatment may be contributing to the patient's condition. Of course, you want to find out about the obstetric and menstrual history, especially with obstetric, like we said, that the previous vaginal deliveries, operative vaginal deliveries, all those are risk factors for urinary incontinence. Then you also want to assess if this patient is physically impaired. As you basically, individuals who have compromised mobility, dexterity, or visual acuity may need to be managed differently. As like I said, with those ones, they tend to have functional incontinence. It's not really the issue of the lower urinary tract. It's just because the patient really cannot really get to the bathroom in time. This busy table here was just showing that different medications that have an impact in the lower urinary tract system. Others will cause the incontinence, others will cause retention, and yeah, others will cause frequency. So yeah. Then you'll then go on to your social history. Here you want to find out about environmental issues, which include social, cultural, and physical environment. You want to find out about lifestyle, if this patient exercises, is a smoker, and the amount and type of fluid that they take, as well as food intake. Then you'll go on to other treatment planning issues now, where all individual needs to be assessed for their ability to fully describe their symptoms, symptom burden, and quality of life impact, and their preferences and goals for care. They must be able to understand proposed management plans and to discuss where appropriate alternative treatment options. In some group of patients, formal testing is essential, which includes cognitive function testing for individuals for whom the clinician has concerns regarding a memory deficit and or confusion, and depression screening for individuals for whom the clinician has concerns about abnormal effect. Like we said, those ones that tend to be just not motivated to go to the bathroom. And if you perhaps address that issue, you'll be able to basically to win with the incontinence. You will then go on to your examination. You look at the patient's general status, the mental status, work out the obesity, the BMI for the patient, and you look if this patient is mobile, basically look for physical dexterity and mobility. And then you'll go on to your external genitalia. Here you look at for features suggestive of genitourinary syndrome of menopause. You look for incontinence-associated dermatitis. You look for hygiene, and you look for urethral meatus and phimosis, as well as paraphimosis. With this one, they tend to occur much more early in life because that is more of the congenital issues. When you go into your abdominal examination, you want to check for masses, for bladder distension, as well as relevant surgical scars. You may find that the patient has had a previous incontinent surgery, which will assist you with further management of this patient. You'll go into your examination of the perineum as well as the external genitalia. It includes the tissue quality and sensation. You want to examine vaginal mucosa for atrophy, inflammation, pain, and scarring. You want to examine the urethra for mucosal prolapse or caruncle, and you go on to your vaginal examination, which should ideally be done in lithotomy position as well as in vertical position. You can use a half bivalve speculum or a sim speculum, which is what we have, and you must be able to assess the patient for pelvic organ prolapse. And ideally, you will use a POPQ staging system. It should be used should you feel that patient is got prolapse. This is just a picture of the POPQ staging system. You will then go into a bimanual pelvic and anorectal examination. Here you want to assess for pelvic masses and tenderness. And you do your digital examination where you want to assess for pelvic floor muscle function, reflexes, as well as the function of the internal and external sphincter, as well as the puborectalis muscle. You'll go on as a screening tool now. Look for neurological examination as well, where you look for tone, strength, and movement of lower limbs, as well as the bulbocavernous sinus reflex. And you'll start with your test. Now you can start with your stress test. This one is done supine as well as standing. It is done to assess the urinary incontinence in the presence of a comfortable full bladder. How it is exactly done. In terms of patient preparation, the bladder should be comfortably full, about 200 to 300 ml of urine. The patient can be asked to void partially if it is overly full. And the test can be performed in lithotomy position, supine with legs apart, or in a standing position, as sometimes leakage is more evident when patient is upright. How you execute the test, then the clinician observes the urethral meatus while the patient is asked to cough strongly several times or perform a Valsalva maneuver such as bearing down as if they are straining. It is positive when there's urine leakage from the urethral meatus synchronously with coughing or straining, and it is negative when there's no leakage despite the increase in the abdominal pressure. Sometimes you may have delayed urine leakage, which may be suggestive of cough-induced detrusor overactivity. And in the case of delayed emptying, or in cases where stress urinary incontinence cannot be demonstrated despite clear symptomatology described by the patient, then urodynamic studies may be an appropriate test. Then we will then go on to the Q-tip test that is no longer really advised. However, it's still there in the literature. This one seeks to assess urethral mobility. It includes visualization of movement of an earbud placed in the urethra, palpation, as well as the use of the ultrasound. And when the urethra is displaced more than 30 degrees from the horizontal plane, with patient straining in the supine or lithotomy position, there will be descent of the bladder neck to or over 25 millimeters, which is regarded as a hypermobile urethra. This, like I said, it has been replaced by transperineal ultrasound as the standard method of urethral mobility assessment. This is due to an increased patient discomfort with the former test, as you can imagine in certain things. Then what about the role of the dipstick? With urinalysis, the main purpose is to exclude underlying infection. This can mimic and or exacerbate incontinence symptoms. It should be, if you have a positive UTI, should be treated prior to further investigations or management. And when there's a positive dipstick, then formal urine microscopy and culture to detect UTI and or use of additional tests such as endoscopy or urinary tract imaging is necessary. When you detect, if there's detection of hemoglobin or glycosuria, this should further prompt further testing, such as testing for diabetes and so forth. Then you'll go on to do your estimation of post-void residual urine. PVR, it should be part of the initial assessment as it is likely to influence management. This is by preference be performed non-invasively, and the high residual volume is more than 150. You basically ask the patient to pee, and then you wait for about 10 minutes, and then then that's when you then do the test. In terms of further symptom and health-related quality of assessment, you then use the bladder diary. It is an integral tool in the initial assessment of urinary incontinence. In patients, basically, with urinary symptoms, the use of a bladder diary is highly recommended. It documents the frequency of maturation, the volume of urine voided. It documents the incontinence episodes and the use of incontinence pad. It is not completely diagnostic, but diary patterns may characterize normal and abnormal state. It is advisable to have the patient complete a bladder diary for 3 to 7 days. This was just the example of exactly what I just said of the bladder diary. And this one also incorporated a part of a bladder sensation. It grades between 0 and 4. And with 4 being if you have agency and could not get to the toilet in time, so you leaked urine, whereas 1 if you had no sensation basically of needing to pass urine, but you passed urine for social reasons. This is an example of a bladder diary of a patient who's got urinary incontinence. You can see this patient goes to bed at 2200 hours and he passes urine of about 240 cc's. 3 a.m. again wakes up to pass about 666, but had an accident at that point, and basically she leaked on her way to the bathroom. At 5 a.m. again, she went to pass urine. and had another accident when she was just preparing to urinate, and then she had. But of course, if you look at this patient, she wakes up at 7 a.m., she passed urine again, 150 cc's, but literally an hour, 45 minutes, she then goes going to the toilet to pass urine, but there's not much to come out. It's only just like 35 cc's, but she still got the urge to say she must go and pass the urine. This one is an example of a bladder diary with patient with stress urinary incontinence. You can see at 6 a.m. she was coughing and then she had an accident. And then at 5 p.m. when she was exercising, she also had another accident. What about the role of renal function? It is recommended only in patients with urinary incontinence where they suspected renal impairment as a consequence. And when it comes to imaging, so imaging of the lower urinary tract and pelvis, it is highly recommended in those with urinary symptoms whose initial evaluation indicates a possible coexisting lower tract or pelvic pathology. And the the ultrasound that we use is the transperineal pelvic ultrasound. This one is just basically, if you look at the picture on the left, this is showing the normal resting urethra as well as the bladder neck. The bladder neck is BN and the urethra is U. And while the picture on the right, there is a significant descent of the bladder neck and rotation of the urethra. This one demonstrates urethral hypermobility. So with urethral hypermobility, it is indicative of stress urinary incontinence, and in its present is a marker for successful anti-incontinence surgery. In the absence of urethral mobility, it may behoove the physician to consider alternatives to traditional anti-incontinence surgery, such as urethral bulking agents. So why do we like ultrasound? Of course, there is no X-ray exposure. There are no allergies. It's easily available. It's dynamic. It's non-invasive, and you can combine it with a vaginal ultrasound as well. In the context of urogyne, or in urogynecological diseases, in those patients who have a recurrent lower urinary tract, the ultrasound will be able to assist us with showing findings such as urethral and bladder diverticular. We can work out the post-void residual volume. Can be able to see if there's an intravesical foreign body. And with urgency and infrequent, again, you could be able to see if there's urethral or bladder diverticular, any periurethral masses, intravesical bodies. You can even see if there are fibroids on the anterior wall. And with this urine, this parunia, you'll be able to see periurethral masses, diverticular of the urethra, and so as an IUCD if it's there. What about imaging of the upper urinary tract? The rationale for imaging of the upper urinary tract is to identify malformations of the upper urinary tract. It is to monitor the effect of urinary incontinence on the upper urinary tract when necessary. It is always indicated in neurogenic urinary incontinence, in myelodysplasia, in severe pelvic organ prolapse. The modalities that you can use is ultrasound, fluoroscopy, CT, as well as MRI. The choice is dependent on feasibility, availability, as well as the expertise to be able to interpret that ultrasound, that scan. So it is, however, the recommendation we have is that you must use the least expensive and the least hazardous technique. And what about the avoiding cystourethrogram? This one assists us with quantifying the bladder capacity. It's able to tell us about the bladder outline, to be able to diagnose vesicular-ureteric reflux and work out the post-void residual volume, and it may detect urethral diverticulum, although MRI is the gold standard for this. This is just a picture of a VCU. The left is normal. It looks normal with a normal outline, and whereas the right image, you can see it's abnormal. It says this abnormal with cone-shaped pattern has an irregular outline as well as outpouchings, and these are suggestive of a neurogenic bladder. With cystoscopy, it is a surgical procedure in which a rigid or a flexible fiber optic endoscopy is used to examine the lumen of the bladder in the case of cystoscopy, and urethra in the case of ureteroscopy. It is not to be used routinely. However, it is highly recommended when initial testing is abnormal, like in cases of hematuria and maybe the history and the examination is suggestive of other pathologies. In cases where pain or discomfort is the main feature in the patient's lower urinary tract symptoms, the cystoscopy may suggest an intravesical lesion, or these symptoms rather suggest an intravesical lesion. Where it's appropriate, it is appropriate in the evaluation of vesicovaginal fistula as well as in extraurethral urinary incontinence. When it comes to urodynamics, it's the general term to describe all measurements that assess the function and dysfunction of lower urinary tract by any appropriate method. It allows for direct assessment of lower urinary tract function by measurement of relevant physiological parameters. It can be differentiated into non-invasive as well as invasive urodynamics. Non-invasive urodynamics are all urodynamics done without insertion of one or more catheters or any other transducer into the bladder. Whereas with invasive urodynamics, it's any test that is invasive as it involves insertion of one or more catheters or any other transducers into the bladder and or other cavities, or insertion probes or needles, which an example they make is electromyography measurements. When to consider them? Ideally, patients with urinary incontinence, they should undergo urodynamic as the bladder is known to be an unreliable witness. Symptoms alone does not always allow for correct diagnosis. However, with limited resources and access to these tests, patients with clear-cut symptoms can initially be managed empirically. So urodynamics studies should not be performed without a clear indication. So you want to perform them on a patient that has mixed urinary incontinence in whom surgery is considered, those who have voiding dysfunction, those that you are considering bladder neck surgery, those who have previous unsuccessful surgery, those who have neurogenic bladder disorders, and when conservative and pharmacological measures have failed. The aims of urodynamic testing is to diagnose, is to prognosticate for us, and is to direct the management and to assess the response to prior therapy. It is to reproduce a patient's symptoms, and then this can be correlated with the urodynamic findings. Is to assess the bladder sensation and to detect filling pressures, especially in those patients who've got detrusor overactivity, and as well as the bladder capacity. It's able to assess urethral competence during filling and to determine detrusor function during voiding. It's able to assess residual urine. With video urodynamics, this one is optional. It may be useful in the assessment of urinary incontinence in some children and in patients who fail surgery, and in those who have a known or suspected anatomical abnormalities of the lower urinary tract, such as diverticular, fistula, or vesico-ureteric reflux, as well as in some neurogenic patients to obtain additional anatomical information. With PET testing, it is an optional test again for evaluation of urinary incontinence, and if carried out, can be carried out either as a 20-minute to about an 1 hour ward or office test with fixed bladder volume, or it can be carried out as a 24-hour home PET test during usual daily activity. So with all that being said, so when do we then refer to a specialized unit? So it's those with complicated incontinence group, those with pain or hematuria, those who have recurrent infections, those who have who are suspected or have proven voiding problems, those who have significant pelvic organ prolapse, those who have persistent incontinence, those who have recurrent incontinence after pelvic radiation, those who had previous radical pelvic surgery, and those who have previous incontinence surgery, and of course those that will have a suspected fistula. Of course, if you are failing conservative and medical therapy, then we need to refer to the right people. In terms of the principles of management of these patients, consist of conservative management, medical therapy, as well as surgical therapy. When with conservative management, it starts with counseling on the patient's condition and setting up realistic expectations and goals that you can achieve with the patient, and then also advising the patient what to avoid, such as some bladder irritants that will be worsen patient's condition, particularly the ones that have got urinary incontinence, and then also involve cognitive therapy, particularly in those ones that may be having depressions and all those, and also doing some bladder tools such as scheduled voiding. Also, there are mobile health apps, mobile health apps that can assist, and then electroacupuncture and agency suppression techniques that can help. And also, it involves lifestyle modification, physiotherapy as well. There's a huge role played by physiotherapy, and to optimize patients' comorbidities, especially if you've got obviously a patient that has got uncontrolled diabetic, and you want to optimize that as before you try and address the incontinence. In terms of lifestyle modification, the general measures such as limiting overall fluid intake are important, decreasing intake of caffeine, alcohol, and carbonated drinks, which are bladder irritants, strategies like weight loss and smoking cessation, and dietary modifications such as high fiber foods, which are recommended to avoid constipation. If you remember, we said fecal impaction is one of the causes, reversible causes of urinary incontinence. So does this sort of weight loss really work? They randomly assigned 338 overweight and obese women with at least 10 urinary incontinence episodes per week to an intensive 6-month weight loss program that included diet, exercise, and behavioral modification, or to a structured education program. They concluded in this paper by saying a 6-month behavioral intervention targeting weight loss reduced the frequency of self-reported urinary incontinence episode among overweight and obese women as compared with a control group. They basically were saying that a decrease in urinary incontinence may be a decrease in urinary incontinence may be and other benefits basically among the extensive health improvements that are associated with moderate weight reductions. So basically, both stress and edge incontinence improves when a patient loses weight through lifestyle changes or by bariatric surgery. When it comes to pelvic muscle floor therapy, so pelvic floor basically it works through strengthening pelvic floor muscles, promoting pelvic floor support and increasing muscle volume. Pelvic floor muscle therapy forms the foundation of conservative management. It's most widely recommended first-line treatment for all types of urinary incontinence in women. There was a meta-analysis consisting of 21 studies, 1,490 women in 2011 that demonstrated that women who undertook regular and continued pelvic floor muscle training with a practitioner directing their exercise and supervising their progress showed superior subjective improvement. Regimens basically that are for stress urinary incontinence tend to focus on muscle endurance, whereas for the ones that have got urgency urinary incontinence, they tend to focus in fast twitch musculature to suppress urgency episodes. It is shown to improve the quality of life in patients with stress urinary incontinence as well as in patients with urgency urinary incontinence. The only shortfall to it is that it needs obviously a motivated patient to be really effective. These are some of the bladder tools that we had spoken about earlier, which includes the bladder training. So with bladder training, it is used in conjunction with other lifestyle modifications to correct habitual frequent urination by gradually increasing intervals between voids. Moderate to high level, there's moderate to high level evidence that supports that bladder training cures or improve urinary incontinence symptoms in more women compared with no intervention. When you are combining it with pelvic floor muscle training, it results in more improvement or cure than bladder training alone in women with all types of urinary incontinence. Agency suppression techniques also facilitate the ability to cope with delayed voiding. The other bladder tools that you can do is timed voiding, habit voiding, as well as prompted voiding. In terms of your pharmacological options, it consists of antimuscarinics, alpha agonist, beta agonist, estrogens, tricyclics, antidepressant, which is a combination of alpha agonist as well as anticholinergics. How do anticholinergics work? They block the bladder receptors, resulting in decreased bladder overactivity and therefore improved symptoms. Examples are oxybutynin, phenylpropanolamine, and festoridine. And with alpha agonists, these ones these ones should result in urethral compression and aid in treatment of stress urinary incontinence. Example is duloxetine and midodrine. And beta agonist These beta adrenoceptor agonists, they work by interfering with bladder neuroreceptors, resulting in decreased bladder overactivity. And there was a systematic review on the efficacy of Vibegron, which is a beta-3 adrenoceptor agonist, which included 3 randomized controlled trials and demonstrated improved urinary frequency, urgency, as well as urge urinary incontinence episodes. The role of vaginal estrogens compared basically with no treatment, hormone therapy, including topical estrogen and raloxifene, has been found to be effective for treatment of mixed urinary incontinence. And with tricyclic antidepressants, imipramine is a tricyclic antidepressant drug with dual class effect with both anti-muscarinic and alpha agonist properties. Its side effects can limit the use of this drug, however, as there is a possibility of arrhythmias. Duloxetine is an antidepressant as well. It has been approved by the FDA as well as the European Medicine Agency for this. These are some of the available main anticholinergics available in South Africa. I think the one that we are familiar with is oxybutynin, although currently it's actually out of stock. In terms of the surgical options, it includes mid-urethral sling, retropubic corpus suspension, pubovaginal sling, urethral bulking, as well as artificial urinary sphincter. With mid-urethral sling, vaginal surgery involving tension-free placement of type 1 polypropylene mesh strip or tape. It's placed between the vagina and the urethra near its midpoint. There are 2 types, which is the TVT as well as the TOT, tension-free vaginal tape as well as the transobturator tape. And then the other option is the uretropubic corpus suspension. With uretropubic corpus suspension, it is an abdominal or laparoscopic surgery involving dissection of the retropubic space in the proximal urethra, which is elevated towards the retropubic periosteal fascia. Can be performed laparoscopically with or without robotic assistance or through a laparotomy. It works by elevating and stabilizing the proximal urethra or bladder neck. With pubovaginal sling, it is an abdominal vaginal surgery that uses a length of fascia, tissue, or graft to support the urethra with an abdominal wall fixation. And the sling material is most commonly autologous, and therefore the procedure has been referred as fascial sling. The fascia from the rectus sheath or fascia lata has been used, but other materials, including allogenic, xenogenic, or synthetic grafts, have been described with varying success rates and complications. With urethral bulking agents, it refers to a transvaginal or transurethral surgery in which a substance is injected into the urethral submucosa at the bladder neck to facilitate coaptation. The aim is to achieve coaptation of the urethra during the storage phase of the maturation cycle and during phases of increased abdominal pressure to restore continence. The types of urethral bulking agents, they can be divided into 2 groups based on the characteristic of the substance injected. 2 types of substance you can inject is the particulate urethral bulking agent, which is microplastic, Durasphere or Captate, or you can inject the non-particulate urethral bulking agents, which is what I think we have is the Bulkamid. When it comes to the role of artificial urinary sphincter, it is an abdominal surgery in which a fully implantable prosthesis designed to reproduce the normal function of the urinary sphincter is placed. It stimulates the normal functioning of the urinary sphincter by closing and opening under patient's control. Urethral occlusion is accomplished automatically and at physiologic pressures approximately 60 centimeters of water by fluid-containing occlusive cuff. These pressures are applied evenly around the bladder neck and proximal urethra, and urination is triggered voluntarily by the patient when she activates an implanted control pump located in the labia majora. This manipulation allows the transfer of the liquid contained in the occlusive cuff to a pressure regulating balloon. The cuff remains open for a few minutes to allow urination, and then pressure rises again automatically when the fluid returns from the balloon to the cuff, restoring urethral closure. And this is just the picture of it. When it comes to the role of neuromodulation, with peripheral neuromodulation, how it works is So lower urinary tract is innervated by nerves arising from the lumbar, sacral, and coccygeal regions of the spinal cord between L2 and S4. The posterior tibial nerve comprises part of the sciatic nerve that arises from L4 to S3. Other nerves which innervates the pelvis are the dorsal genital nerve and the pudendal nerve. So peripheral neuromodulation stimulates these nerves and therefore affects a change in the lower urinary tract symptoms. It's performed in one or two ways, either by means of dermatomal stimulation or by stimulating the nerves through the overlying skin. With posterior tibial nerve stimulation, basically external intermittent neuromodulation such as PTNS, they send electrical stimuli to sacral nerve plexus via a 34 gauge needle inserted at 60 degrees angle just above the middle aspect of the ankle. Then patient typically receive 12 30-minute treatments on a weekly basis, and thereafter treatment cycles may need to be repeated periodically. Subjective symptom improvement has been reported in approximately 60% of the patient, whereas objective improvement in the frequency of voiding child parameters of up to 57% with good long-term consistency has been reported as well. It may be considered in patients with overactive bladder or who have shown a poor response to antimuscarinic. With sacral nerve stimulation, it works on a similar basis to peripheral nerve stimulation. It acts via direct stimulation of the sacral nerve to modulate the afferent and efferent impulses to and from the bladder. It is currently FDA approved for overactive bladder, non-obstructive urinary retention, as well as fecal incontinence. This table basically is the summary of the whole talk. Basically, it looks at, I'm not really going to go through all of it, but basically it starts from the history, the clinical assessment, the presumed diagnosis, and the managements that you can offer to these patients. And then it actually even tells you when to then send to the specialized team to have a look at the patient. So in conclusion, the diagnosis is based on symptoms assessment through a detailed history assisted by bladder diaries and examination. Where the presentation is complex or unclear, further information and investigations are warranted. Investigations such as urodynamic studies are usually reserved for patients with refractory symptoms or those who choose invasive treatment. There is evidence to support the use of ultrasound for non-invasive assessment, and conservative treatment are the recommended preliminary treatment owing to their high safety profile. Pharmacological treatments are the usual treatment following failed conservative therapy. And before commencing treatment, it is important to explore the patient's goals and their goal attainment, as this may provide useful information to guide treatment-related decisions. Thank you. Thank you.
Thanks, Dr. Malo. So I think there was a lot of information overload, but hopefully, it refreshed some of our minds, and we'll open the floor to any comments or questions. I know Dr. Ramphal is on leave today, so I'm not sure if he joined remotely, but maybe Prof. Naidu in Maritzburg is online and would like to comment. Yeah, no problem, Prof.
Yeah, thanks, Dr. Ngumara and Dr. Naika. You mentioned pelvic and perineal ultrasound. Pelvic, yes, maybe with a full bladder. How many of our sonographers, or you mean that scan will be done by us as a gynecologist, or how many people really have the skill of perineal ultrasound and be able to delineate the bladder diverticular the urethra?
So thanks, Prof, for that question. Yeah, actually, a lot of these guidelines and these, and all the societies, I mean, most of it is either a urological or urogynecology society, or and a lot of our information is from the latest Incontinence Society. So when you look at transperineal ultrasound, it is quite a new modality that's been introduced in the last few years. So most of the focus is upskilling at the urogyne level rather than the general gyne level. But in saying that, if you are afforded the opportunity for that training, it's quite a simple bedside tool. It's easy to use, and with a lot of the softwares now in the ultrasound machines, there is more AI input now for urogyne or pelvic floor issues. So once you actually apply the transperineal probe in the right position and you have the correct landmarks, then the machine kind of does the rest for you if you've got the right position. You may just have to draw maybe 1 or 2 lines and it will give you the rest of the information. So it is nice, and Dr. Ngalo did list all the benefits of doing it. And yes, putting in a catheter to measure the residual volume is a little bit invasive and has some discomfort, and same with the Q-tip test. But at this moment in time, those things are not in the museum. They are still very practical and very useful, and we should still be performing them. There is some discomfort, but it's a quick, short test. You lubricate the pus swab, and it's very useful and easy to identify that 30-degree angulation. And it helps us in our decision making for a lot of our patients in terms of which treatment options are available, or which would be more beneficial to them. So even us in urogyne, we are still upskilling with transperineal ultrasound, but it does give you a lot of information. And at the same time, we're tackling only urinary incontinence today, but we know a lot of patients will have multifactorial pelvic floor disorders. So sometimes you may not appreciate prolapse clinically, or the patient may not mention it, but you may pick it up on the transperineal ultrasound.
Like still in bed.
Yeah, the person that has done the most
Did his PhD
on the endoanal, but Prof. Zila Abdul in Pretoria is probably the most proficient in ultrasound at the level of even 4D ultrasound, which can be quite helpful.
That's the next learning.
Yes, yeah.
My plea is that let's develop that expertise locally, and you are the right person.
Thanks, Prof.
Can continue the Q-tip. My next question was on the TOT and the TBT. You just and you didn't tell us which is which. What's the advantage of one over the other, and so forth.
I'll take the blame for that one, because Dr. Ntutuko wanted to to make everyone urogynecologist at the end of the talk. But no, definitely, Prof. I just thought when this topic, where it was broad on urinary incontinence and not on a specific type of incontinence, if we focused purely on stress incontinence, then we could have gone nicely into detail. I thought for now we actually even missed Botox in the overactive bladder patient. I think we accidentally omitted it in the slides, but I think these were just eye openers, just to pique everyone's interest to go back. We know some of us are not familiar or too clear with the retropubic and the transobturator tapes. There are various differences between the two, but and we have to be aware of it. And the procedure is not limited to urogynecologists. The issue with these procedures is that to get good outcomes and minimize complications, you need volume. So that's why it's been moving away from the generalist and more the from the gynecologist to the urogynecologist, because of numbers, and it is a foreign body that you're putting, and treating the complications of mesh is the biggest challenge. So you want to try and limit that risk, is why it's preferred to be done. But I mean, even some urologists are also trained, and obviously from an industry perspective, they are very keen to train you and take you somewhere and do a course. And even if you read the leaflet, it says if you've observed 5. I don't know which brand it was, but sometimes some of them say if you've observed 5 or even you do, it's not mandatory to have performed 5, then you can go ahead, which, it's not easy, and you have to have a good understanding of the anatomy and the pelvic floor before performing it. It's not just about make incision 2 centimeters and push needles. So, so I think that's just something to be cautious about. But what we want people to understand is, I know when Dr. Tutuko saw the title and his name next to it, and he said, "Whoa, it's a Urogyne talk, Dr. Naika." And I said, "No, it is a gyne talk. It's in your book. The gynecologist should be able to have a decent make a decent evaluation of the patient, have a working diagnosis, implement management, because at the we as gynecologists are where the patient is most likely to present, not really the GP or other physicians, very rarely the urologist. So we need to be able to afford these women the appropriate care. I know the prevalence is actually quite high, it's quite significant, but it's probably even underestimated. And as we are progressing and women are being more educated, they are presenting earlier, and it affects, as much as the prevalence increases with age, it affects women of all ages. So stress incontinence is not specific to age, so that can present much earlier. So you got to be a little bit knowledgeable about how to evaluate these patients and implement therapy. First line and second line therapy to the pharmacological point is easy to implement. So if you've taken a good history, you've done an examination with a few bedside investigations, you should be able to have a broad idea. It's the one where you're really not sure or it's not matching where you're going to say, okay, I think we need to refer, or you implemented some therapy and you want to refer. And we know, as Dr. Maise coined the term the commercial aspect. You guys are going to be, those who are already practicing are the ones that are going to be doing these treatments. You're not going to send one days, except for Dr. Ramphal, there's no urogyne in private, and he isn't even full time. So you have to be you are the forefront players in managing incontinence. I think Dr. Ngalo mentioned that oxybutynin, recently we've noticed we're getting some phone calls even from patients to say they're not receiving their oxybutynin, and some of them are actually, and it's the ones who are pretty responsive to it, even on low doses. So they're quite distressed that for the last 3 months they haven't received their oxybutynin. It is the only drug we have available in public sector, so it is a crisis. We haven't run out yet, but I'm sure it's a matter of time, because initially I think we only had heard from Addington, but now the Addington patients that were referred to us that reported it, but now there's other hospitals that are starting to have the same issues. So
even the private pharmacists don't have
the oxybutynin. So it must be a supplier issue more than a funding issue from the hospital or from government. And I think it's just to reiterate the importance of conservative management, because a lot of our patients, sometimes I tell the patient, just to conceptualize, if you're a diabetic taking metformin, doesn't mean you eat the chocolate cake, So to say that will balance the sugar control. The same applies to the bladder. If you're going to be having 3 or 4 cups of tea or coffee and say, oh, I'll take the oxybutynin, it suppresses my symptoms, then, you're not winning. You could have actually avoided it. It has lots of side effects, or maybe reduce the dose you required if you just implemented that. And we see it, our patients, even after coming to our clinic after a few years, you just, take a new history and say, but what are you drinking? What are you doing? And the elderly like their teas, and some are coffee drinkers. So you got to, empower them to take some control of and take some responsibility in their management. The pelvic floor muscle training is such an important treatment modality. However, even in Albert Lutuli, there is no one that is, there's no physiotherapist that is dedicated to the pelvic floor. Plus, with the resources, they don't have the time, because you should, the physiotherapist offering good pelvic floor advice actually does even internal examination or part of an internal assessment during the physiotherapy to make sure the patient is contracting the right muscle groups, because often just telling them, and it's not just Kegel exercises, I think that's the misnomer, that is one, part of pelvic floor training. But if they don't do that, then they're busy squeezing the gluteal muscles instead of the pelvic floor. And we know, when we tell patients to lose weight, and either they go to the gym today and expect to stand on the scale and see a difference, and the same applies to the pelvic floor. It's you have to be consistent and motivated in order to see results, and you're going to only see that in about 8 to 12 weeks if you're doing it consistently. And just with the Kegel exercise, for example, to be effective, you need at least 40 to 50 contractions. So often patients, you tell them you can do it while you're sitting and watching TV, but sometimes that's actually a bad idea, and they should actually have a focused moment and do these exercises to make sure they've done the correct amount and done it correctly. And weight loss. Weight loss in the pelvic floor disorders is a big game changer. We've seen it reduces your symptoms. It's not curative, but reduces your symptoms by 50%. And when you are creating targets and expectations for your patients, it can be a game changer if you can motivate them, beside all the other benefits of weight loss. So, yeah. Any other questions or comments?
If you got therapist next year to give us a talk, what do you think?
I don't know if our physiotherapists are going to be, even in private, there's very few that are pelvic floor dedicated. There's in government. Okay. Okay. So okay. That's a good idea.
It was quite good. Yeah, we'll see.
Okay.
But do you think it's a good topic? Because at the moment, it's like we're telling patients to squeeze the wrong direction.
Yeah, I think we as the clinician don't have a lot of information, but it takes a lot of time, which most of us don't have in the consulting room, and giving a pamphlet is not enough. And you don't have to have supervised consults to have efficacy of pelvic floor muscle training. We know even if you teach them and educate them, it can be effective, but we all know if it's supervised, and then you get a better result. So, but from a resource perspective, that's not practical. But there are devices, we just touched on, we can do a whole talk on pelvic floor muscle training. I know we did one a few years ago in Maritzburg, so it can take the whole hour on pelvic floor muscle exercises. So it can be, done. Yeah, and there are devices. So, you can do exercises, but you can add biofeedback. So, some physios will have biofeedback in the rooms, but patients can also, that's where the apps, and you can actually buy where there's a small cone you can insert in the vagina, and then it will show the patient that they are actually squeezing the right muscle group. It becomes almost like a game where you're going to try and reach certain goals, and then it becomes a bit user-friendly to the patient, and it motivates them. When they can see they're doing something well, then it motivates you mentally to keep pursuing the modality. So these things are available. Any other questions or comments?
I don't see any plan. I don't know what you want here.
Just an observation and a comment. So obviously, when it comes to detrusor instability, the edge incontinence and all that, it seems to me that the GPs do initiate the treatment, because once they've taken the history, they are able to do that. And by the time the patients often see us, especially in commercial, they're already on these treatments. that they've been initiated by the GPs themselves. Because it doesn't seem like it's a rocket science story of food instability. I feel I want to pass urine, it leaks out and whatever not. It's a straightforward story. Obviously, it is the stress incontinence that obviously, or the mixing content that really requires a bit of expertise in terms of that. But I think one of the things that is underrated is a lifestyle change, especially the caffeine containing kind of drinks and the carbonated drinks. And the patients underestimate the impact of the negative impact of that. And I can tell you from our prostate experience, because we are in that age of the prostate, that when you reach that age and you start having this difficulty in voiding and you have to double void, you void and then you have to go back again and void because the residual is a bit higher in terms of that. Touch the coffee, you will really be in serious trouble. Touch anything with caffeine, you're really in trouble. And touch things with carbonated drinks, this fizzy drinks, you are in dire straits. And don't even try it when you're traveling, when you're driving. It's like a disaster.
So I think, you know what, I think, as much as Dr. Maise mentioned some personal information, it's true, and I think we shouldn't actually be laughing, because that's why the bladder diary is so important. It's for those little things where if I couldn't go back now, but if the yellow page one, it actually shows you that the patient, after they had consumed coffee and a glass of water, then they had almost 3 episodes of needing to go to the toilet. So, and our patients, I don't know if anyone else has experienced it, is they said, no, as soon as I drink water, doctor, I go to the toilet. And then I say, well, the water's still in your stomach. It hasn't bladder. So that's not what you're peeing. But it's obviously what they do is wake up in the morning, have a cup of tea or cup of coffee, and then they know they must drink water because it's so healthy for you. And they start drinking a glass every, hour or two. And then within an hour after consuming all of that, you've hit a bolus, like of a diuretic. And then our patients are on diuretics and consuming tea and coffee. And some patients don't have a teacup of tea. It's so for 50 ml. So it's not just the tea, it's also the volume. So we mentioned limiting fluid. We mentioned limiting fluid intake, but there's no magic number. And I think maybe we're doing good in a sense that I think the communities are hearing about the 2-liter magic number, but sadly that 2-liter is not a one size fits all. Your patient on 3 antihypertensives or even cardiac disease hears about the 2 liters. So they're taking Lasix and Spiro and all of that, and also trying to drink 2 liters. One patient has a 5-liter, and then you're like, I don't know if we can actually fix your problem unless you. So you have to tailor it. You don't want to dehydrate your patient, but you shouldn't be encouraged. So you got to tailor it individualize it to your patient so that it's important. And we mentioned caffeinated, but maybe it's more anecdotal and not look for some evidence, but it's not very clear, is even rooibos. I don't know if anyone has ever personally drank rooibos, even if you don't have a bladder issue, but maybe 30 minutes later you are in the bathroom with a full bladder. So rooibos is just as powerful as the caffeinated teas.
It was not have caffeine. That's the distinction.
But I think, but there is. Have rooibos, Dr. Maise, and
Rooibos was the tea that we grew up on because we never drank anything caffeine. Right? And after a while, when I became an adult, I dismissed the story and I started drinking the normal tea and and the coffee that we never drank. But when the prostate came in, there is a significant difference between rooibos tea and other tea than coffee. In fact.
No, really. I mean, we have patients and they said, oh, but I'm drinking green tea and I'm doing this. And I said, actually, it's maybe not the caffeine on its own as the only confounding factor. There's some patients who are fine with coffee, but tea is worse, or vice versa. So you have to tailor it. So, like someone with IBS, and you say, look at which foods trigger you. You're gonna also do that with the bladder. So it takes some time, but your patient will be grateful in the long run, because these are, they're not as difficult as your endometriosis patient to manage, but they can be quite difficult. And if you don't set realistic expectations, because not everybody can be cured. And also not everybody is looking for cure. You may think you want her to be dry. She actually just wants improvement of symptoms. So, and the severity is not only based on quantity, it's based on, multiple factors. Some patients who have the toilet easily accessible at the workplace next to if the office is near the bathroom, or at home they have close access to the bathroom, frequency doesn't affect them. They can go all the time. They actually don't complain about it that much. Whereas the patient who has to go outside and works, cells on the street and doesn't have access to the toilet the whole day, then her symptoms may not be that severe, but her situation makes it severe. So you got to individualize and have patient directed goals. Okay, so I hope everyone is now more comfortable and doesn't say, I didn't read this topic until I reached urogyne rotation, because that is our commonest comment we get. I haven't done incontinence because I didn't come to urogyne. I just want to emphasize it's for everybody. And we are just the people who deal with the patients you don't want to manage. Okay, thanks everybody. Yes.
In our part 2 exam, we were asked a 60-mark question. Surgical management of stress incontinence for 60 marks. So it's a gynecological problem. It's not a urogyne. Of course, it's in the bladder, but everybody's you don't have to do the procedure, but you need to know what is available to be done. Just for noting, save the date. The closing party is on the 15th of December. You'll get more details. So it's on a Monday, the day before the 16th, which is a public holiday. So try and make so you'll be available. I'm sure we won't have taken a long trip out of town. Okay.
Thanks, everyone.
Thanks.
Thanks, Malo.
Hold side.